Nikhita, can you hear me?
Hi, yeah, I can hear
Yeah.
you well. Okay, that.
Yeah. Can you see my screen?
Yeah, I think, yeah.
Okay. Yeah. Good evening, everyone. So, we welcome you to the second session of the RadOcean Viva series. So before we start, so I'll just go briefly on the current pattern. So, we have 30 minutes to Viva stations and 15 minutes with each examiner. So, we'll have four examiners. You'll be spending 15 minutes with each, and they will be showing you three cases each. So that will make 12 cases. And now the present scoring domains are radiology knowledge, observation, clinical reasoning, safety, and management. So this is just an overview which is given in the official RCR website, how they score along the cases and domains, and this is the description of it. So, so we'll start with the first candidate. So do we have the first candidate? Do we have candidate number 2? Dr. Rabia Khan, candidate 2.
I think you have to
Yeah,
unmute her, Suhas.
I'll just unmute her. Yeah, candidate 2, are you there?
Hello.
Can you hear me?
Hello. Can you hear me?
Yeah.
Yes.
Okay. Nikita, you go ahead.
Yeah, okay. Yeah. So as you can see my screen, right?
Yes,
Yeah,
I
I can
can.
see.
Okay, great. I'll just give you remote control.
Okay. Should I start?
Just a second. I'm giving you remote control. Yeah, you should
Okay.
have it now. You're ready, right?
Yes.
Yeah. Suhas, could
Yes.
you start the timer? Yeah, I think we can start.
Okay. So this is X-ray abdomen AP view. I can see that there are multiple dilated bowel loops seen in the abdomen, predominantly in the central distribution. And these are likely the small bowel loops, as I can see the valvular conventi. I'm trying to look at the cause for this dilation. And I cannot see any definite radiodense calculus within it. In my normal practice, I also look at the erect X-rays that cover the diaphragmatic region to look for the free air under the diaphragm, as well as the hernial orifices region, lower pelvis, to comment on this. Um, I'm trying to look if I can see any evidence of the free air in these images, which I cannot see definite. There are degenerative changes within the spine. So this is the thing that I can see, that there is a small bowel obstruction, and it's an emergency. I would urgently inform the referring doctor, and this patient needs further evaluation with the CT abdomen and pelvis to look for the cause of the obstruction and urgent surgical referral.
Yeah, this is the CT of the same patient.
Okay, so okay, now it's just scrolling. So this is the CT scan images of the same patient. I'll first scroll all the images and then I'll start commenting. The NG tube seen in place. Okay, I'm going till the last cut to not miss anything. There is a consolidation is seen. Basal consolidation is seen in the right lung base. And okay, I'm just scrolling it.
You can use the
It's
scroll
taking.
bar on the right if you want. Yeah.
Okay, thank you. There is ascites seen. This scroll bar is not working for me. Okay, I think I should just scroll through the mouse.
Sure,
Okay,
sure.
I can see that there are multiple dilated small bowel loops seen in the abdomen. I'm going till the last cut to look for the cause of it. There are nematosis coli also seen. There is abdominopelvic ascites seen. I'm trying to look for the cause of it. Okay. Yes, there is no evidence of the any obturator hernia. Uh, I'm sorry, the scrolling is taking a bit of time.
Sure. I can
Uh,
just drive you back on top. Is that what you want? One
yeah,
second. Just leave the mouse.
yeah, yeah, yeah. That
Yeah.
that would be great.
Yeah. Okay.
Okay. Yeah. Okay. There are multiple dilated bowel loops. There is air in the images. I also saw that there was branching lucencies within the liver, suggestive of the air in the portal vein. However, I would like to see if it's in the portal vein or in the uh, okay. So yeah, the air is seen in within the portal vein. I would like to see the contrast images to comment on the vessels. As a okay, so these are arterial phase images of the same patient. I'm trying to see if I can see the thrombus, any as I'm suspecting mesenteric ischemia in this patient. Um, okay. Mm, The
Do you want to scroll? You
mesent
can scroll now, I think. Just use the mouse bar to
yes.
scroll.
Okay. Yeah, I am scrolling, but I think there's a leg. Uh, can you please scroll for me,
Sure, sure.
if possible? I
Yeah,
want to
yeah.
see the mesenteric artery. Uh, okay. Uh, Yes, I can see that there are atherosclerotic changes seen within the mesenteric artery with a filling defect within it. This is suggestive. This is a case of the mesenteric ischemia that is causing the small bowel obstruction. I would, in my normal practice, I would also look at the lung window to look for the perforation and the bowel wall as well to look for the ischemia within the bowel wall. Yeah, the bowel wall is not enhancing. I'm suspecting infarcted bowel loops as well. Can I see the lung window to comment on the perforation and the free air? This is a case of the mesenteric ischemia that is causing the small bowel obstruction. I will urgently inform the referring doctor as it's and urgent referral to the surgical team as it has already infarcted and this patient needs surgical management.
We'll move on to the next case.
Okay.
Yeah, this patient comes with a severe headache.
Okay. So these are MR images of a patient presented with a severe headache, and this is a diffusion weighted images of a patient presenting with severe headache. I can see that there is a uh, okay, yeah, this is diffusion weighted image, right? Uh, I can see that there is no significant or subtle patchy or diffusion restriction is seen. Yeah, which I would like to correlate with the ADC finding there. And I would also like to start with the T2 weighted images. Uh, to start giving my findings. However, in this image, I can see that there is an abnormal signal intensity area seen in the right, seen in the left parieto-temporal lobe. Uh, um, yeah. Hello.
Yeah,
Hello.
yeah. You can scroll now. Yeah, we can hear you.
Okay.
Candidate 2?
Okay. Yes. Hello. Can you
Yeah,
hear me?
yeah. We can hear you. Yes.
Okay. Actually, I think my internet connection is not that stable. Um. So I can see that there is an abnormal signal intensity area seen in the left parietal and the temporal lobe that is causing a significant midline shift and as well as parafalcine herniation and also causing the uncle herniation, and it is showing patchy peripheral diffusion restriction. I would like to evaluate this further on the uh, T2
Okay, this.
weighted
Okay,
images.
sure, sure. Just a
Um,
second. Yeah.
okay, so on T2 weighted images, I can see that there is an abnormal signal intensity area re-demonstrated in the uh, left parietal and the temporal lobe with it's basically a cortical subcortical based lesion that is causing significant midline shift in the compression, and it is also causing effacement of the ventricle and contralateral dilatation of the lateral ventricle. Can I see the uh, T1 weighted images and the post contrast images as well?
What do you want to see in that? Yeah. We don't have a
I
plain
want
T1. This is
on
the top image.
okay. I've okay, I'm trying to uh, okay.
Do you want me to scroll for you?
Yes, please. That would be great. So uh, there is there is um yeah, there is patchy. You said that no T1 contrast image is available, right?
No, no T1
So
contrast images available.
uh
Nikita, 10 minutes.
okay, so
Okay.
no definite contrast enhancement is seen. I'm suspecting that there is an element of hemorrhage in it, and this is a cortical based abnormal signal intensity lesion, and that is causing significant marked effect. I would keep the differentials of the aggressive neoplastic lesion, cortical based aggressive neoplastic lesion like oligodendroglioma and so I would urgently inform the referring doctor this patient needs urgent neurosurgical referral and decompression as it's causing significant mass effect.
Do you want to take a look again at the flare and the T2 weighted images? Do you have any
Uh,
other differential apart from neoplasm?
Okay, can I see the yeah, I want to see the flare images. I've just okay.
I think you can use the center button
Uh
in your mouse to scroll because it's just like 15, 20 slices. It shouldn't be an issue, I think.
okay. Yeah, there is hyperdensity also seen within the transverse sinus and the extending into the internal jugular vein. So, yeah, I would retract my finding, and this is a case of the venous sinus thrombosis and associated hemorrhagic infarct. I would urgently convey my findings to a referring physician, and would also correlate with the MR venogram images.
Go to the next case. Yeah.
Okay, so this is X-ray chest frontal projection of a patient whose history has not been provided. I can see that there is homogeneous opacification seen in the right upper in the mid zone. There is loss of lung volume also seen in the right lung with diaphragmatic elevation. Other than that, there is no pleural effusion is seen, and uh, no pneumothorax seen. I'm trying to look at the bones now to see if I can see any bony erosion, which I cannot see. So uh, uh, there is a yeah with the element of as it's involving the upper lobe and with element of the volume loss. I would keep the I would keep any obstructing lesion that is causing the volume loss and the in the upper lobe, any hilar mass. Yeah, and the second differential I would keep of any infective etiology if patient has history of fever. So I would evaluate this patient further with the CT chest contrast.
Yeah, this patient actually did have history of fever and raised inflammatory markers. So are you seeing
Okay, so
anything else? So what type of infection do you think this could be?
I can see that there are internal bronchiectatic cavities are also seen within it, um, uh, uh, and it is also causing mild bulging
Candidate two?
of the fissure as well, and there is chronic granulomatous infection like tuberculosis prior in tuberculosis. Hello,
Yeah. Please
hello.
continue.
Yeah, yeah. I'm thinking in the line of the chronic granulomatous infection. I would correlate with the history of the patient if the patient has any prior history and correlate with the prior X-rays available, and yeah, and HRCT chest for further evaluation. And a sputum AFB smear testing and gene export would also be helpful. And if it's come positive, then patient needs isolation and imaging of the close contacts as well.
Okay, great. I think your time is up. So we'll just go to your feedback. So this case, I think you did well. Actually, you picked up most of the things. So starting from this case, you did. So basically, there's an opacity and there is bulging of the fissure, and there is also volume loss, like you said. There is tenting of the diaphragm with some non-homogeneous opacities. And there is internal cavitating foci, which you are seeing. So you said bronchiectatic changes. Better word would be to say some lucency within or cavitations,
Okay.
basically. And I like that you mentioned that there are no rib erosions that you were looking for it. So neoplastic and infective, those are the two differentials, but it's good to give a conditional differential. So if the patient, had a fever and this, I would be thinking in terms of this, or if this was something that was long-standing symptoms, then if this was an
Mhm.
older patient, I would be thinking in terms of neoplastic. But overall, in this case, you did well. Let me just look at my notes. Yeah. So when you said bulging fissure, I thought you were going to say Klebsiella. This was actually a case of Klebsiella pneumonia. But even TB, because of the cavitation, and if you see carefully, there are also few calcifications within. So that is also a good differential. And your management was correct. You would isolate the patient and further refer it to the chest team. So yeah, ideally you would refer it to the chest MDT. I'm not sure if you said that. In between, your voice kept getting cut. I think you're having some internet issues. So
Yeah.
yeah, uh, in this case, I think I
Okay.
would give you a between a 2 to 3 because you picked up most of the findings and your diagnosis was ultimately correct. But I would expect you to give more conditional differential and refer it appropriately to the chest MDT. But yeah, overall in this case, you did well.
Okay.
Now, coming to the other cases, so one thing I noticed with the other two cases is like when you're presenting, yeah, your knowledge is good, you know the things, but it is not so systematic. It seems a bit haphazard. I think there was also issues with the scrolling and everything.
Hmm.
But yeah, it should be a little more systematic, and I would advise you to give a little bit of gap also when you are speaking, right? So you're continuously speaking, you should give a little gap in between.
Hmm.
I'm seeing this, like pause for 1 second. So
Hmm.
if the examiner wants to
Hmm.
jump in and help you,
Hmm.
they'll get that time. Oh, I actually
Hmm.
interrupted you, I think once or twice, but in the exam, they will not be doing that. They never interrupt the candidates. So make sure that
Hmm.
you take small pauses. If
Hmm.
you read the examiner's reports also, they tell you to take small pauses in between so they can
Hmm.
offer you some information or help you. Okay, so that
Hmm.
is one
Okay.
feedback for both these cases. So yeah,
Hmm.
this case, I think you were scrolling in the wrong aspect of diffusion. So you went down basically to the B1 images. Here you are seeing
Okay.
hyper intensity in the ventricles, so which should be hypo. So yeah, peripherally you are seeing diffusion restriction. This case, actually, you could have taken a clue by just looking here. Here you're seeing SWI
Hmm.
images and there is so much blooming. This will not be there in
Hmm.
the exam, but try to look for any clue,
Yeah.
say some nuclear medicine
Hmm.
study, below there it could be
Hmm.
written there what study it is. So if you are seeing any
Hmm.
clue in any of the images, like try to pick it up.
Hmm.
Uh,
Hmm.
but yeah, so along with that, there was also a few other areas of diffusion restriction, but mainly the thing you had to pick was the large hemorrhage here. And when
Hmm.
you are asking for the next sequence, so what you
Hmm.
would say in like try to say it like in my routine practice, I would like to look at the GRE images to confirm whether there is blooming. And then the examiner
Hmm.
will give you than saying, can I? So if whatever you are asking, don't say, can I or may I get this like that. Say like, I
Hmm.
would next like to look at this to
Hmm.
rule out whatever. You
Hmm.
need to give a reason. And same thing with the
Okay.
history also. Like if the patient had these symptoms, I would be thinking of this. Like it's better not to ask a leading question. Yeah.
Hmm.
So
Hmm. Hmm.
this case actually,
Okay.
I don't know whether it was the scrolling issue or what. So basically, this is a large lobar hemorrhage. So the first thing you need to be
Okay.
thinking about is a CVT because this is not a hypertensive
Hmm.
hemorrhage. It's not in the basal ganglia.
Hmm.
So
Hmm.
and it is lateral. So first thing, if you get this kind of case in the exam, you would try to look at the transverse and the superior sagittal sinuses.
Hmm.
This should have been picked ideally in the T2 or the
Hmm.
flare images itself. So you're seeing there's loss of
Hmm.
flow void here. And
Hmm.
yeah, and there's also intraventricular extension. The mass effect you described well, that there is significant compression, everything. So if you are not finding the cause for this and you know that it's an urgent case, so this patient has to go to OT urgently. And so what you should say is, I will immediately pick up the phone and inform this finding to the clinical team. You see a hemorrhage, there should be like an urgency in your voice. I see a large hemorrhage. It's extending into the intraventricular region. It's causing mass effect, significant mass effect on the
Hmm.
brainstem, uncal herniation. So before I go
Hmm.
further, I'd immediately pick up the phone and inform the referral that this patient needs an urgent surgical
Hmm.
consult. And next, I would look for the
Hmm.
cause of this. So then you say, as I'm scrolling down, okay, I see that there is a thrombus. And then you go through the rest of the images. Then you would say, I would want, I like to look at the venogram images to confirm my
Hmm.
finding, basically. So
Hmm.
yeah,
Hmm.
this case actually there is also so I was expecting you'll ask for the GRE, and because you didn't give any gap, there was nothing much I could say in between also. So this patient even has thrombus in the straight sinus also and internal
Hmm.
cerebral sinus also. It's but I even if
Hmm.
you had just told about this thrombus, I would have still passed you. But this is an additional finding.
Hmm.
If you wanted to get
Hmm.
like a 3 or a 4, then you can now pick it up. But yeah, so this was seen on T1 also. This is a TOF image. I think you got confused in between and you said there is no contrast enhancement. So just be careful. Don't go too
Yeah.
fast. Just take your time and take short pauses. Don't get too tensed.
Hmm.
And yeah, now that it's
Yeah.
not as bad as before because you're
Okay.
only having 3 cases. So,
Hmm.
you don't have to like freak out and speak really quickly. Yeah, so this
Hmm.
is the venogram where you're seeing on the opposite side there is no flow in the transverse, and also we are not seeing the straight sinus or the internal cerebral veins. Yeah,
Yeah.
and if for those of you who are
Yes.
watching, additional findings are these diffusion restriction in the watershed territory. These are in fact arterial infarcts because of increased venous pressure because of the capillary backflow. But anyway, that is not something I was expecting you to say. Yeah, that was only like if you wanted a 4 or anything. But yeah, so this case, I don't think I can pass you. I probably have to give you a 1. You did pick up the finding, so that was good. But yeah, between a 1 to 2 in this case. Yeah. Um, Coming to this one. Yeah, what else? Yeah, so this case, I think X-ray wise, you told most of the findings. So I'm not sure whether you said supine radiograph, but yeah, that's okay. You're not seeing an erect annotation here, so you can say supine abdominal radiograph. You mentioned the valvulae conjumentis and that the small bowel loops are all dilated, and you were looking for a pneumoperitoneum sign. So there is no regular sign, basically. And also, if you see carefully, that you can see the pneumatosis here as well. It may be quite difficult. So even if you didn't pick, I think it's okay. But just try to look at all the corners to look for
Hmm.
these findings. So these are multiple air foci within the wall itself. And in this case, yeah, I think you went too fast in the beginning itself. You were looking for radiodense cal, then you said degenerative changes. So it was a bit haphazard. So first describe all the bowel findings and then you go for other findings. I don't see any obvious radiodense calculus, or I'm looking at the hernial orifices. I don't see obvious bowel loops in the hernial orifices. You can say that. And yeah, apart from that, I think that's it on the X-ray. So mainly bowel dilatation and pneumatosis. Again, same thing for this case also. You have to say like pick up the phone and immediately inform and arrange a CT for this patient. So coming to this, yeah, this part you did well. You picked up all the findings. Like even though you had some scrolling difficulty, you still picked up the pneumatosis, the portal venous gas, and also the thrombus. So findings wise, yeah, I think you did well in the CT. So you were looking for pneumoperitoneum also in the lung window. That was fine. And yeah, so in this patient, you said like I'd like to see the arterial images. So in exam, you won't be having these. So when you look at the plane, you can say stuff like, so if this patient was on table, I would immediately advise contrast study to look for these things. Like I would immediately go and get it done. And again, same thing, more urgency in your voice because this is the gangrene. He has to go for immediate resection. Okay, I think the images are still loading. But yeah, I think you can also add things like there is thinning of the walls and no enhancement of the wall. I'm not sure if you said that. And yeah, I think
Yeah, I
this.
said that about the infarcted bowel.
Okay, okay, fine, fine. Yeah, I think this case you
Hmm.
were fine. I'd give a 3 on this case. So overall, yeah, your radiology knowledge is good, but just keep practicing every day with a study partner and to be more systematic and so that all these things which you're supposed to say, it's just second nature. So any case you get, you will be presenting in the same manner and you're very, very systematic. That is what you should concentrate on and see as many cases as you can and incorporate all these things. Try to go through the
Yeah.
examiner's notes as well. Yeah, but you still have quite a bit of time, and in the exam you will not have all these other issues. So yeah, just do that. Yeah. Suhas, you want to
Thank you
add
so
anything?
much.
Yeah,
Sure.
Nikita, can you just answer one question is there in the chat?
Yeah, I cannot see it. I
Any
think
right
you'll have
mid-zone
to.
calcification in the chest X-ray?
Yeah, I mentioned that there is calcification here in this region. So that is one more point towards tuberculosis. But in this case, we had also thought of both tuberculosis and infective etiology. And retrospectively, it came back as Klebsiella. But yeah, you do see the bulging fissure sign, and both DDs you can give. They are quite close. Yeah. Yeah, to answer your question, there is calcification, yes.
Yeah. So candidate two, so she has given extensive review. I'll just point out what I have listed down. So first thing, when you started with the case one, so especially in the CT, don't start with the findings such as consolidation in the lung base and all. So start with saying that you'll go through the entire stack of images, then you'll come back to the findings because you already know you're dealing something with the bubble. So don't start with consolidation, effusion, so that won't be nice. And in the when you're scrolling, can you hear me? Is the voice low?
I can hear you, Suhas. I
Yeah.
think she has got muted. I think you will have to unmute her.
Okay, one
She
sec.
might have.
Uh, can they-
1 second. Let me try. Yeah, I have asked to unmute.
is she? Is it there?
Her internet is a little unstable.
Can you hear me though? Well,
I can hear you well. Yeah. There's no issue with. Yeah, she's
Yeah,
back.
yeah,
yeah.
your voice is clear.
Can you hear me now?
Yeah.
Yeah, so that's what you don't start any findings, especially in cross
Yeah.
section, in the beginning itself, especially when you have started with the radiograph and you know what is the abnormality. And you were saying in that bowel pathology, you're telling you're looking for a cause and all. So it would be better what you're looking if you mention that you want to look at hernial orifices. You can use a broader terminology rather than just saying you want to rule out directly saying there's no obturator hernia because you may have to say 4 5 times to say that there's no obturator hernia, there's no femoral hernia, no inguinal. So better to say you're looking at hernial orifices, something like that. And so first, better you somehow I felt you are going here and there. So somehow you're describing the positive, then you go complications, some come back to negatives. So better you describe the positives, then go to negatives, and then go to complications. So
Okay.
if you have any bowel related
Okay.
dilatation, you want to first go transition, then you want to look at small bowel, large bowel status, then go to complications, free air. Did you mention no pneumoperitoneum though?
I
She
asked
did
for the
actually.
lung window to comment on that.
Yeah, so that would be fine even if you ask that. Then you were telling when you already picked out SMA thrombosis and all, just don't use the word again that you are suspecting ischemia. Directly say it's an ischemic bowel process going on. Because if you say that, you will suddenly
Yeah.
sound little not confident. So when you have picked up SMS thrombose, cutoff, filling defect,
Okay.
whatever you said, so then
Hmm.
immediately
Hmm.
link it that you are dealing with the ischemic thing. One good thing I'll tell you with
Hmm.
the present processes, they will not give you a thin section. It will not be a 600
Hmm.
700 image stack. You'll have a thick section and it
Hmm.
will be appropriate to what is needed. And other than
Yeah.
that, I think because of the thick section and the present scenario, I don't think your speed would be good. Your speed will be adequate for the present scenario. And in the second case, I felt when you started with DWI, you should have told with lot of hypointensities, you should have told that's a T2 blackout effect, and you should have directly asked for SWI as the next sequence. To you could just say it's a lot of
Hmm.
hypointensity. I want to this is looking like T2 blackout. I want to look at SWI to rule out hemorrhage first. That would have been the best thing.
Okay.
Then you were asking a lot of
Hmm.
sequence. You want pre T1, post contrast. You will lose a lot of time on that. and in between you are just having long pauses. So just keep speaking, that would be better. And you're saying sentences like after the prompt, hyperintensity in sinuses and all. So just be careful what you use. So you use the correct terminologies. So if in case you put it neoplasm as this neoplasm instead of hemorrhage and infarct, you will be marked unsafe in the case 2, so definitely. So in the case 3, I think you're okay with the most of the things. So in case 3, I would give you around 2 to 3 knowledge, observation, reasoning, and safety. But in the 2, I would be just maybe knowledge 2, observation 2, reasoning 2, but safety, I would give you 1. In the first case also, I would score you similarly 2 in the all sections. Yeah. So all the best to you.
Okay. Okay. Yeah. Thank you. Thank you so much.
Welcome.
Stop
So
sharing.
yeah, do we have candidate 3? Okay,
Yeah, I
candidate
see
number
candidate
4.
3. No, I
Yeah,
see
yeah,
candidate 3. Oh,
yeah,
Hi,
candidate.
I'm
Hi.
candidate 3.
So can you tell your
okay.
name because you didn't respond in the group?
Yeah, I'm Khalida.
Candidate 3, Khalida Kurihada.
Yeah,
Okay, okay, done. We'll start with you. Nikita, can you keep the time?
Yeah, just a second. Yeah, you can share your screen.
Yeah,
I'll
I'll
start the
just do
timer
that.
after that.
I'll just share in a minute.
Sure.
Yeah, can you see my screen, Nikita?
Not yet. Yeah,
Can you see? Yeah. Candidate 3,
a
you're here?
second.
yes,
Can you see my screen?
Yeah, we
yes,
can
now.
see the marking page. Yeah.
Yeah.
Okay, I'm starting the timer now.
Yeah.
Yeah.
So a middle-aged patient with chest pain.
Okay, so I've been presented with axial chest frontal projection of skeletally mature patient. I can see that there is an opacity which is occupying the left lower zone, but I can see the costophrenic angle clearly. There is also some loss of lung volume on the left side. I can see air fluid level just in the retocardiac location. So I'm suspecting hiatus hernia in this case. The other possibility could be this is cardiac abscess. If the patient have any history of recent surgery, so it may represent post-surgical changes. So I will check the clinical history of the patient, compare with the previous imaging if available, and further evaluation with CT chest is suggested in this case for confirmation.
Okay. What are the top 2 differentials?
So hiatal hernia is my top differential in this case,
Yeah. Next is
or eclasia is the other possibility. As the patient is old, so secondary eclasia or pseudoeclasia, other possibility. So further evaluation with the CT is suggested for confirmation of these findings. If this is eclasia, then manometry and swallow can be done to just confirm all these findings.
okay. Can you tell me how do you differentiate achalasia versus hiatus hernia?
In eclasia, there is on swallow, like if we do
Just
barium
go on the
swallow
radiograph. Just on the radiograph.
on this radiograph,
Yeah.
I cannot. In hiatus hernia, there is air fluid level, but in yeah, I can see there is indistinct border of the hemidiaphragm on the left side. So in hiatus hernia, there is indistinct border, but in eclasia, it may not. It may be clearly visualized.
Okay. So we'll go to the next case. So here is a patient who has pain in the foot. I'll just give you the remote control. You're named candidate 3, right?
Yes.
Okay, 1 second. Can you ask me for remote control? I can't see it.
Okay, I'm requesting.
Yeah, you can go through. Yeah.
Okay, so I've been presented with actual actual T1 images of the foot of a patient who have been presented with pain. First of all, I'm just going through the images. Can we a little bit pan up the image as there is message on the screen which is obscuring my view?
I'll just move you. Just give me a second. Just give me a second.
Okay.
Yes, 1 second. Go on.
Okay, thank you. So again, I can see I'm just going through the images before describing them. First of all, I'm just going systematically. I'm just checking the calcaneum and talar bone, which appears marrow signal of the bones appears preserved. There is, I'm looking at the navicular, which also appear intact. May I note the patient's pain site? Is it mid portion or okay? Or in the... So I can see that there is a altered signal which is present along the head of the second metatarsal. So I am just checking. I will confirm this finding on other view. Otherwise, I am just looking. The marrow signal of the most of the bones appears preserved. I am checking for the presence of any step. There is no step in the region of second tarso-metatarsal joint, and I'm checking now joints of interphalangeal and metatarsophalangeal joints. So I cannot find any obvious abnormalities. So I will further evaluate this patient on fluid-sensitive images.
Okay, can you just summarize what you have seen in this sections?
I have gone through all the bones
No,
just to
tell me
check
the
the
positive points.
Okay, so there is an altered signal which is present along the second metatarsal head, which appears low on this T1 images, and I'm also, yes, I just only suspecting altered signal in the region of head of T2, second and third metatarsals of this foot.
Okay. So, okay, here is the fluid sensitive.
Okay, so again, I'm just scrolling the images. Okay, so on fluid sensitive images, I can see that there is significant edema and fluid seen around the second metatarsal head. I'm suspecting a stress fracture of the second metatarsal. But it is involving whole of the second, like it is involving the head, which is so it is involving the head of the second metatarsal. So I am suspecting again the findings are suggestive of stress fracture of the second metatarsal of the foot. So I will convey immediately the finding to the referring physician and further evaluate this patient with X-ray of the same region and physical physical mobility may be altered or reduce the physical activity just to allow the healing and or immobilization with any foot boots suggested in this case for further management.
Okay. So why do you need X-ray though?
Um, like in my routine practice, I'll always correlate with X-rays just to
No, for
confirm my
example, it's
findings.
not done. So it's I've given you the first as MRI. So do you want to radiate because you asked for X-ray again?
Sometimes it's good to have an X-ray to just to exclude most of the things. But if it is not needed, I will clinically discuss with this with the clinicians. If they still suggest to, so I will go for an X-ray.
Okay. So can you tell the stage of this stress fracture?
I'm just checking the epiphysis, height, and sorry, I cannot uh, recall the classification for this stress fracture class.
Okay, no worries. What is the expected management for this?
For stress fracture, only immobilization and altered physical activity suggested.
Okay. Okay, done. So we'll go to the third case. So here is a patient who has come with headache.
Okay. So I've been presented with axial flare images of a patient who have been presented with pain or headache. So first of all, I'm just going through the images. Okay, so I can see there is no midline shift and see it's going again, jumping, sorry. I'm just going systematically just to there is no obvious abnormality up till now. So I'm just going to my review areas. I'm checking the cortical surfaces. There is no abnormal signal or altered signal in the gray-white matter junction. And I'm just going to check the orbits. Your orbits appears normal to me. I'm just going to check the sella. There is no obvious abnormality in the cellar region. And just want to check the foramen crowding at the foramen magnum. So I can see that there is slight tonsillar herniation is seen along the spinal canal or medulla. So I just confirm this finding on sagittal images, and I'll further evaluate on sagittal images
Okay,
if available.
I'll just tell you. There's no tonsillar herniation. Anything else you want to see? Any other sequence? Anything?
Yeah, I just need to see T2 images or
I don't have T2. Anything else you want?
fats at T1 post contrast.
Post contrast. I'll just see whether I have it. I don't have that.
Okay, then SWI or GRA images.
Which one?
SWI.
Yeah, go on.
I am just first going through the images. There is slight lag on my side.
It's okay, go on.
Okay, so I'm just going through the images to check for the presence of any blooming artifact to suggest I'm suspecting blooming artifact along this in the sulci and gari. So I'm suspecting chronic subarachnoid hemorrhage condition in this case. So I will further evaluate this patient on post contrast. As I'm suspecting subarachnoid hemorrhage. So further evaluation with FLAIR images if available. No, I've already seen FLAIR images. So T1 images.
Okay, 1 second. So I'll just give you this. Go on with this.
Okay. These are T1 post contrast images of the same patient. I'm just going through the images. I can see a delta sign. There is no enhancement of the superior sagittal sinus. So superior sinus thrombosis is suggested in this case as or I will yeah. So there is a filling defect which is present on the left transverse sinus, superior sagittal sinus. So I am just this suggests dural venous sinus thrombosis. So immediately convey the finding to the referring physician, and further thrombolysis is suggested in this case for further management. I cannot find any hemorrhage to suggest a venous infarct, ischemic hemorrhagic infarct. So yeah, so this is just superior sagittal sinus thrombosis.
So do you want to see comment on other things, anything?
Okay, I will check it again.
20 seconds left.
Yeah.
So here I can see that there is high signal is seen in the again posterior part of the superior sagittal sinus, but I could not find any hemorrhagic infarct or any other thing in the provided. Okay, so I can see that there is a dissection of the sorry, I cannot find further any abnormality.
Okay, then I'll stop you there. So we'll
Okay.
go with the review. So first, 1 second, just give me a second. Nikita, can you see my screen?
Yeah.
Yeah.
Yeah, can you see? Can you hear me?
Yes, sir.
Yeah. So before we go to review, I just pasted. 1 second. I'll just clear this. Okay. Okay, so I've just pasted the Google Forms link, so you guys can just fill in the chat. So that has
Okay.
for CPD points, so you can just fill it. It's in the chat. So candidate three. So first thing, so we started with 1 second. Case number one. I'll just show you. So the chest X-ray. So this one you immediately went to the positive finding. So he said, so there's a retrocardiac opacity with air fluid level, and later you just said there is possible volume loss and haziness. And the other things you should have gone through is, one is, after the airflow level, I wanted you to comment on the fundal bubble, and later I wanted to say that you actually, the moment you pick a finding, you usually put a diagnosis. That is what I saw in the most of the cases. So don't put a diagnosis. So after you describe, go on with it. So say retrocardiac opacity, air fluid level, there's no stomach bubble. So then you also see it is such a large fundal air fluid level. For that, I'm not seeing any upper posterior mediastinal dilated shadow to suggest a dilated esophagus. Then, so I'm in thinking in view in lines of hiatus hernia, and I'll also look for lung bases to rule out aspiration. And you also gave the differentials like achalasia, pseudoachalasia. You can say this looks like a patient who is a adult or a old patient. So pseudoachalasia, I want to, if mass lesion, if I am to rule out, I look at the bones for any secondaries. So these kind of things, you only have to make it up and say that you are looking for any secondary. So bones look normal, soft tissues normal, and lung bases are is okay. So that is how I'm thinking of hiatus hernia. So then afterwards you have to say that whom you will refer. You will refer to the upper GA team, would be a better team, a better term to use. Then they'll ask with the previous imaging, if any previous endoscopy or swallow it's already done, then you can correlate with it. And you were saying with differentials with multiple investigation, your knowledge is good, so you have to just sort it out step by step and don't give a differential at the beginning itself. Also, you gave a word called retrocardiac abscess, so that would be little off of the diagnosis, because I just said onset of chest pain. So you can, if you want to put such diagnosis, please tell if the patient has an acute onset of fever, who is very febrile, very septic, then I'll consider a lung abscess with a large air fluid level, like a conditional differential. That would be great. Then you said I will look for recent surgeries, all those are good. Then so that would have been good. So that was the first case. So
Thank you.
then coming to the second case of the food, I started with T1. So usually they will give you the sequence. They will not allow you to choose the sequence. So that's why so fluid sensitive, you will immediately see it. So usually they start with the thing so that to see the approach, how will you go. So you were going, I'm looking at this bone, all that were fine. So when you said your altered signal, then you can just say this is hypointense on T1, and it is at a site where common for stress fracture. So I'm concerned for a stress fracture. I don't see any step, no Lisfranc injuries. So what I'll do is I'll check with fluid sensitive sequence. Then when you come to the fluid sequence, you described all this. So when I give you the sequence, if you find the window is bit odd, you can ask for it and you can just narrow down the window, and you can go by step to step that there is a lot of edema in the metatarsal centered around the head neck junction, a lot of intermetatarsal soft tissue edema. And then you can correlate in the T1 what I saw, the hypointense band, and it is hypointense here, so that must be the fracture line. So I'm looking for any other fractures or any other stress reactions, any other focal bone marrow edema, no collections. So I will also look for DWI to look for any restriction, you can say that. Then you can at the last wind up by saying this would be stage 4. So we start with periosteal edema, bone marrow edema. At the last stage 4, we will have a clear cut fracture line. So that would be T1. So in this, you said picked all the findings, diagnosis, referral. So this would be good. Even if you say staging, that's not a problem. That's and you said X-ray. I think you could just say whenever CT X-ray comes, you can just say I'll correlate with the previous X-ray done. Consider it, it's already done, so that you don't have to come up get on with the same question. So that was it in the second case. Then I think this will close on what. So in this case, so first thing is you went, there's no parenchymal abnormality, all that were fine. And the other thing I wanted you to pick in this is when you said review areas, come to the flow void, how is it? So there is hyperintensity along the posterior aspect of superior sagittal, transverse, and sigmoid sinuses. Then, then afterwards, if you had picked that, then you should have commented on there is no venous infarct. I look for DW for venous infarct and also look for auto mastoid and middle ear for any collection, otum mastoiditis, secondary. So you have to say the findings and the complication and the cause for it. You have to search in 3 levels. So after that, I gave you the post contrast sequence, the angio sequence, which you said, one sec, I'll just, okay, I'll just Okay, I'll just tell you the feedback. So in that, you should have told that because you could have also see that it's a TOF images. So don't commit that it's a post contrast images, because also remember in the study when you asked me post contrast, I told you I don't have post contrast. So listen to examiner if they say that that particular sequence is not there. And when you ask for a when you go for next step, make sure you don't say opposite to what already information is given. And when I started, usually they gave a short history like headache or something. So you have to stick with it, because in the foot, I said pain in the foot. So you can't now exactly ask where is the tenderness point and all. So usually they will not answer such. They will try to ignore you. And apart from that, you pick the venous infarct once the TOF images were given. Then you should have used the word, I'll pick up the phone, this is a medical emergency. I'll call the urology team, and I'm concerned with this may go for a venous infarct, and this will need anticoagulation. So when I said, do you want to look something else? So I would appreciate. Okay, she has been muted. She's telling. Nikita, can you just unmute her?
Yes,
And, okay, I've done that.
that's done it.
Okay. So
Okay,
when
thank you.
when they ask, for example, if you end it early, they'll ask you, do you want to give any extra information? So that time, if they put a particular sequence, definitely there will be something they are expecting you to comment. So in that case, I was expecting you to say there's no mastoid or any middle ear collection, and there is no venous infarct. You know that that particular knowledge you will have, but you have to show it that you are looking for the complication and you are looking for the causes, because you
Okay.
would really want yourself to be safe. And you have to say wherever is emergency, you have to say that you will pick up the phone and you'll immediately call. You have to say which is the department and which is whom you will call, and whatever you want to say, you have to say. And in emergency, and whenever it is a complex case, you have to bring a component of MDT, because in this case there was not a big MDT chance, but at least if the patient, the case one where there is hiatus hernia, you can say that I'll discuss with previous imaging and all. So if there is any further findings, we'll discuss this under upper J MDT for further discussion and management, you can say. So that's it. And when
Okay.
I asked
Thank
you
you,
for the
sir.
last one, you said dissection word. So you're dealing with venous things. So if you don't say anything, then that's fine. But don't use something emergency and like something off a dissection, RTL dissection. So that goes and takes you away. So I would score
Okay.
you in most of the cases into clinical safety, reasoning, knowledge, and observation. And in the last case, I would put you 1 in the clinical safety. So just be careful. You in all the 4 sets, you will have 1 emergency cases. So whenever it is emergency, just show some more like that you are that you how carefully you will try to manage the case. Nikita?
Okay. Thank you so much.
Yeah, welcome.
Yeah, I don't have too much to add. So I think your pace is good, your knowledge is good, and you handle the questions also pretty well. So you're going in the right track, and you can just take whatever feedback you have gotten from Suhas as well and incorporate that also. So first 2 cases, actually, I think you did well. First case, since it is a chest X-ray, if you want, you can say like, okay, lung fields are clear, and then you can jump into the abnormality so that they can tell that you have a systematic approach. But yeah, you did well in that case as well. In the first case, I would give you a 3. And in the second case, yeah, so like he said, in when you are asking for another sequence, you should give a differential. Like you can already tell that it is most likely edema because it is hypointense on T1. And you can say, just to confirm this, I would like to look at the fluid sensitive images. And yeah, so in that case, I think in most of the things I would give a 3. Observation would probably be a 2 because you kept a little bit of beating around the bush even after you found the abnormality. But still, that was also fine. And third case, yeah, I think that would be a problem because you had just seen the previous case also, which was a venous infarct and there was loss of flow void. So you definitely should have picked it up. So just how in CT it is important to look for the dense MCA sign or dense basilar, in MRI it is very, very important to look at the flow voids. I liked your approach, how you had the review areas well done, but you missed flow voids in review areas. So in MRI, make sure that you keep flow voids as part of your review areas and always look for it. Not only this, if there is like any basilar occlusion on MRI, so try to look at that. And yeah, rest again, even in his case, in the side, we could see that it was written TOF venogram. So just look at these clues and don't get yourself in trouble so that they think that, you don't know the basics or anything like that, since we'll be quite tense. Yeah, but in the last case, I would also have to score you a 1. But the other two you did well, and your approach and everything is good. So yeah, all the best.
Thank you so much. Thank you.
Yeah, I'll just answer those few questions. So, yeah, so there was no subarachnoid hemorrhage. We started with the flare. So, whatever you were seeing on the SW, the congested veins in the cortical veins, and in the flare, there was no high signal in any of the sulci. So, flare would have been the best to say SH. So, there was no SH in there. Then, so that's what the cause of sulcal blooming was congestion, and the thrombosis was in the posterior third of superior sagittal, transverse, and sigmoid. So that's it. There was no parenchymal hemorrhage, no infarct, and there was no otomastoiditis. Okay. So I have pasted the link of the Google Forms of review. So please fill in, and I have put it in the group also if you missed the link. So we'll follow up with the next session, one last session for before the Jan session, one last one. Anything,
I
Nikita?
think somebody else is asking a question, was if Freiberg disease can be kept as a differential for stress
Okay.
fracture.
So Freiberg is the avascular necrosis. Here you could see that in the T1 there was a hypointense line. There was no uh, hypointense loss of bone, or it was not a acute on chronic stress kind of fracture. When you see the T1, most of the cortex was intact. There was no volume loss or no T1 hypointense where there you'll have a typical on the typically when you see on the avascular necrosis. So this was at an acute stage where you had edema in the bone marrow, cortical and parosteal and intermetatarsal soft tissue. So this was at an acute stress fracture level. So if the same patient, if it not treated or something, so definitely one of the complication would have been Freiberg or the AVN, which would set in the future, I would say. Okay,
Yeah, that's
then
it.
thanks for attending. So see you. Good night.
Good night, guys.